Good afternoon, everybody. This is Dr. Mark Rudolph, Sound's Chief Experience Officer. Thanks very much for joining us on this week's COVID-19 clinical webinar. As always, we will have some Q&A at the end of the presentation, so you can submit your questions in the chat box that's at the bottom of your control panel. You can do that any time during the presentation. We're recording this, and we'll send an email to all the invitees with a link to the recording as well as links to the resources that are mentioned. And at this time, I'd like to turn it over to Sound's founder and CEO, Dr. Rob Bessler, to share a few thoughts before we begin. Hi, Rob.
Hi, Mark. Thanks, everyone. And thank you all for joining today. And I just wanted to kick off the call with our esteemed colleagues, clinical leaders on the call today who are going to give us great updates. And just thank everyone. You know, we are all getting through this together, but there's no one more important than the folks on this call, the folks that are actually caring for the patients every day, showing up, and regardless of the circumstances. And the stories from our heroes are just remarkable, and I'm just so grateful to each and every one of you. In light of the most recent set of current events around racism in America and the tragic death and murder of George Floyd, we at Sound really are appreciative. I'll speak for myself, super appreciative of all the positive feedback that's come my way from how we initially have responded as an organization. But the important thing is that your ideas come forward. So if you have ideas on how we at Sound can make the world a better place in our communities and where we serve, please reach out. My emails are rbessler@soundphysicians.com. Annie Fowler, our Chief People Officer, is leading an effort across Sound through our various affinity groups that are under our broader concept of Sound, of an organization of diversity and inclusion that we've had ongoing. Obviously, we've been focused most recently on how are we going to enhance our efforts as it relates to Black Lives Matter and our Black professionals network at Sound. So please send your ideas forward, and I'll turn it back over to you, Mark, to get on with our clinical webinar today. Thanks.
Thanks very much, Rob. And I'll introduce our presenters. As usual, we have with us Dr. Nate Ruck, CMO of Sound Emergency Medicine, Dr. Greg Johnson, CMO of Sound Hospital Medicine, and also Dr. Sergio Zanotti, CMO of Sound Critical Care. And if we go to the next slide, I'm just going to go over the agenda real quickly. First topic we're going to talk about is clinician wellness. And actually, the CMOs asked me if I would talk about this topic first to kick off the webinar, given how important this issue is at all times, but now in particular with the events that we've been facing over the last few months. And then we're going to talk about coagulopathy and COVID-19, as well as antiviral therapy, and get an update there, and talk about acute unscheduled care during the pandemic, and we'll follow that up with some Q&A. So let's start off with clinician wellness. Now, I don't really want to take us back to March 1st. I doubt anybody wants to think back to that time, but when we first started hearing about COVID, obviously there was a lot of uncertainty, a lot of fear. A lot of this has continued, but we've come a long way. However, at first, let's go to the next slide, really the whole world that we see every day just changed. The faces, the behaviors, even the way patients flowed through the hospital changed. And this was obviously anxiety provoking, and we experienced a lot of tragedy in the midst of this. And next slide. At the same time, we were also faced with the specter of becoming ill ourselves. Not that we don't understand that possibility day in and day out, but more so now than ever, we're kind of in the same shoes as our patients, and that we could get this illness just as easily as they have. And so that obviously has been terribly frightening. If we go to the next slide. And over time, we've learned a tremendous amount, even as evidenced by these webinars. We've come a long way in our understanding of how to take care of these patients effectively. And we've seen lots of victories across the country. And, particularly our hospitals with high volumes have discharged a lot of patients with COVID illness. Next slide. However, we've also seen just an incredible amount of suffering across the country. And even if you don't work at a place where there's a high volume of COVID patients, and even if you don't work in the hospital at all, the pain and anguish that is visible in the losses that we've faced is really just incredible. And I think clinically that these outcomes don't really match the tremendous efforts that we've been making. And this is just, it's really hard. It's really hard to deal with. Next slide. The natural reaction for many of us, and I think this is often the case for healthcare professionals, is that we tend to isolate ourselves during these difficult experiences. And I think everybody's pretty clear that there's a culture of stoicism within medicine. And, unfortunately, that just doesn't serve us well. It hasn't in the past, and it's probably not going to now. And next slide. As a population in general, we clearly have some mental health vulnerabilities to begin with, as evidenced by some of these statistics. Physician suicide, to start, there are 300 to 400 physician suicides each year. The rate of those suicides per 100,000 people is more than double that of the general population. We've already seen some suicides in the wake of COVID, not surprisingly. When we look at PTSD, specifically looking at the 2003-2004 SARS outbreak, a study done a few years later at one of the big hospitals that was, very significantly exposed, showed a PTSD frequency of about 19.3% amongst doctors and nurses. Now, granted, there's clearly an impact that is related to one's exposure. So, the closer you are to these things, the more there is a likelihood of PTSD. But this just tells us that there's high risk for some of our people. Next slide. Now, there is some good news. This isn't all going to be a sad story. If we look at PTSD symptoms after exposure to trauma, and this particular example actually comes from a study that was done looking at victims that were present at an armed bank robbery in the UK. And what they found was that substantial PTSD symptoms, so you think about things like anxiety and flashbacks and hypervigilance and those sorts of things, as time goes forward, you see at times zero, actually, that about 60% of people have substantial PTSD symptoms. So to some extent, we really are still at time zero with everything that's going on. And so what we're seeing, the initial reactions of people to all the things that they're facing, really is entirely normal. But rapidly after that, as things start to either be normalized or simply become just part of our everyday routine, you can see that the number of people experiencing these symptoms drops off significantly. This study was retrospective. There was no intervention. So essentially, almost 90% of people, ultimately, all of their symptoms are going to resolve. And then you're left with about, you can see 10% here who will have some PTSD-like symptoms. Let's go to the next slide. So the question becomes, what helps? Because obviously we can't do anything to ameliorate some of the circumstances that we're seeing. I mean, we are seeing suffering on a grand level. That just is. But what does help? Well, a couple of things that aren't surprising, but some that we need to make an effort to be mindful of. So next slide. The first thing is strong leadership has been shown to be very impactful. So leaders who are caring, who are looking out for people's safety, even if they can't specifically fix everything, people that work under these leaders do better in terms of PTSD-like symptoms in the setting of crises and traumatic events. So Not particularly surprising. Next slide. Here's the piece that maybe, wouldn't occur to a lot of us. Social support, and when I say social support, this is a term that's used in psychology research. This is non-professional, formal or informal colleague support. Social support is extremely impactful, more so even than support by mental health professionals. And a lot of that is because people simply are much more comfortable talking with their colleagues, people that clearly understand what they're going through day in and day out and who they have easy access to. Next slide. There are numerous studies, many meta-analyses looking at data around this sort of thing. Almost all of it is in the military and with first responders. But this is just an example of one where social support is significantly related to the mental health among first responders, similar to that of the relationship between social support and post-traumatic stress disorder symptoms. So we can feel good about the potential to use social support to help all of us. Next slide. This was brought home for me a little bit just yesterday, as a matter of fact, when I received an email from my Headspace app. I don't know if any of you have the Headspace app. It's free for healthcare providers, among other people. But normalizing some of the emotions and the feelings associated with what's going on right now is one of the key things that's achieved through social support. Understanding, just because you hear everybody around you feeling the same way, that it's okay not to feel okay. And some of the comments that were in this message from the app, nothing about the world feels normal right now. So why should we expect that of ourselves? Resisting justified feelings of anxiety and stress only creates more tension. Next slide. So I wanted to share a couple of things with you that are useful. Fabienne Moore actually sent me this article that was posted just at the end of last week. This is in one of the ACP journals, but it was written by a couple of palliative care docs who are at Harvard, and they talked about preventing a mental health crisis. There were two particularly useful group activities that I thought were worth sharing. One, they talked about fostering community through weekly bereavement rounds to process grief over patient deaths. And I think that what's important here is that the structure of this can be very loose, and we don't necessarily have to put a lot of process around this, and would encourage the creation of a space for you to grieve over the patients that we've lost in the midst of this pandemic. Also promoting vulnerability with weekly reflection rounds to talk about feelings related to things that have gone well and maybe some things that haven't gone well. Some great team activities potentially next. And then on an individual level, something we've talked about in a couple of different forums recently is the concept of battle buddies. A battle buddy is simply a peer who offers mentorship and emotional support by virtue of having a similar role and work environment, and gets together with their other battle buddy to have a recurring check-in, to just debrief about things and listen to one another in order to accomplish the things you see listed here. Most importantly, validating experiences and identifying stressors, and something that's not listed here, which is to help people when maybe they seem like they do need more help than just talking to a friend or a colleague. Next slide. We do have a handout that you can get on the Knowledge Center. It's on the Wellbeing page. That is just a simple one-page how to do battle buddies. It's about as simple as like me asking Greg, hey Greg, you want to be my battle buddy? We decide when we want to get together and talk. And that's about what there is to it. It's a really great thing you can do. Next slide. I wanted to make one point about self-care. Self-care often feels like a very pressure-filled responsibility that, I've got to do all these things for myself. There's a long checklist. I got to eat right. I got to exercise. I got to sleep well. All of these things can be made into social support activities, whether it's exercise, going for a walk with a friend, eating well, sharing some recipes with a group of people and deciding that you're all going to make the same thing and then talk about it, or even, sense of purpose, religiosity and spirituality. We all obviously have different thoughts and feelings about religiosity and spirituality, but we also have leaders within the hospital. We've got hospital chaplains who specifically make it an effort to speak to everyone, and we can invite them into our spaces and our meetings and take advantage of their perspective as well. So there are lots of ways to create social support through even self-care. Next slide. And then, of course, there are some formal social support programs, and Sound has our peer support program that offers confidential opportunity to talk with a trained volunteer peer responder. We have definitely had people who have called and requested peer support. And one thing that I can tell you from just feedback from the responders is that universally they have felt like they have absolutely helped folks in the conversations that they've had. And so, I would simply encourage you to yourselves or encouraging others that you hear are struggling to give the peer support program a try, because we've got folks who are really eager to talk to their colleagues. Next slide. And then just formal support through mental health professionals, because this obviously is something that some of us may need at some time or another. And all this information can be found on the Wellbeing Portal on the Knowledge Center. But obviously, telephone numbers for the National Suicide Prevention Lifeline. There's also a physician support line that's external to Sound that has volunteer psychiatrists that's available from 8 a.m. to 1 a.m. And then Sound, of course, has for all of its colleagues the Employee Assistance Program, which can help with any life issue that you may be facing. Next slide. Just wanted to point out the Wellbeing Portal on the Knowledge Center, which you can access and find all of this information, as well as a lot of self-care activities. Next slide. And I just want to close by saying that, I think that we're just really fortunate to have all the people around us in the amazing hospital communities and the teams within Sound. And so I just encourage everybody to not suffer alone. And it is true that we will get through this together. So thank you all very much. And I'm going to turn it over to the CMOs for the rest of the presentation. Greg?
Thank you, Mark. I think I speak on behalf of, well, certainly myself, but the other chief medical officers in wanting to make sure that we put well-being first, because fundamentally, well-being is a part of how we have to care for COVID patients. If we individually and we collectively aren't well, then we can't do the job that we're being asked to do with respect to caring for our COVID patients. And so I really want to thank Mark for an excellent overview and reminding us on a consistent basis, not only in this webinar, but in other venues, that we have to make sure that we're paying attention to that for us to do the job that we've committed to do. Second, I would really like to, before we jump forward into the slides, I would really like to echo Rob's comments in terms of thanking everyone for the fantastic work that we're doing. I know that we didn't provide data with respect to the number of cases, and I think people are aware of the fact that in Southern California, Arizona, Texas, Florida, among other states, we're seeing increased number of COVID patients. Our real focus here now is to make sure that we continue our vigilance in terms of identifying what's going on with COVID, and in particular, making ourselves aware of the evolving circumstances. And to that, I'll be speaking to what's going on with coagulopathy in COVID-19. Now, this has been discussed before in both the hospital medicine and critical care venues, with specific highlights on what's gone on with COVID-19 coagulopathy. The intent here is to go over the basics in terms of just reminding everybody of why it's important clinically, going a little bit over the histopathology and the implications that it has for clinical considerations, limited view of pathophysiology for our patients. The reason being is that a number of the pathophysiologic concerns that have been addressed are like everything else in COVID. There are as many questions as there are answers, but we do want to provide some visibility. And then lastly, just getting into the clinical considerations about the coagulopathy and what it means for our clinical care. So we're here and on the basics. And the first component that I want to emphasize is that when we're talking about COVID coagulopathy, primarily we're discussing thrombotic complications. And as you can see here in the first bullet point, we're talking from observational studies to case reports, anywhere from between 16 to up to almost half of the patients having some form of thrombotic complication. To put that into context, Sergio shared with us in a prior critical care webinar that the typical incidence for a critically ill patient in the ICU for thrombotic complications, specifically venous thromboembolic complications, is about 7.5%. So we're talking about more than double at the low end. And so when you're thinking of COVID, you want to also be thinking, I need to be aware of clots. The other basics that go along with this, please go back a slide, are really thinking about the fact that there is something unique about COVID-19 associated coagulopathy. Yes, we know that there's SIC and DIC, which we see in other severe infections, but what I'll report out a little bit on subsequent slides is really what that difference is and how we can identify that. Next slide, please. So just jumping into histopathology, first, the hallmark is really diffuse small vessel thrombosis. If you really want to focus on what it means for COVID-19 infection and thrombosis, it's everywhere. Venules, arterioles, capillaries, and it doesn't seem to care what specific organs that it's going after: heart, lungs, kidneys, found in mesenteric fat. As Sergio had informed us in the autopsy reports that had come out of New Orleans fairly early in the response, what we've found are that there are very specific findings. Number one of which is that CD4 lymphocytes are aggregated around some small blood vessels, and that contains thrombi, what you see to your left in terms of thickening of alveolar capillaries within fibrin thrombi, and then a pattern of tissue damage, again, associated with microvascular injury that may be complement mediated. Some of that instructs us about the laboratory findings that we'll go into next, because you will find that there are lupus anticoagulant and other antiphospholipid coagulants that may be positive in COVID that we're still trying to map out and figure out what they specifically mean. Next slide, please. So what this means for us clinically is that if you're thinking of COVID, you should be thinking of clotting. On the arterial side, that there is stroke, acute coronary syndrome, and other thrombotic events on one side. As you see on the far right with venous thromboembolism, what we brought up before, that patients are going to have DVTs and pulmonary embolism. And then obviously at the microvascular level, that there is some form of coagulation. So thinking of COVID, you want to think of clot and thrombus formation pretty much everywhere. Next slide, please. So if we're going to make sure that we're going to consider that, we want to make sure that we're providing some visibility into laboratory testing and determining whether or not your patient is at higher risk. The table on your left is from the Journal of Thrombosis and Thrombolysis, and a couple of areas to highlight. First off, in terms of differentiating COVID-19 versus coagulopathy versus DIC, you can see that the fibrinogen level is elevated, and in DIC it's down. The other component that, please go back, that we have in terms of other areas where the platelet count in COVID-19 is either going to be mildly elevated or flat. Now, as it says in the first bullet point, thrombocytopenia in general isn't seen in these particular cases, but for severe cases, particularly as seen by our critical care colleagues, thrombocytopenia is associated with higher mortality, and so something that you should be paying attention to for our patients. Other things that you want to consider in terms of laboratory testing are the fact that PTT is going to have some variation with it just because a patient has COVID-19, and so if there's heparin dosing associated with those patients, you want to monitor anti-10A levels as opposed to APTTs. The last bullet point is the one that I really want to make sure people take home, and that is that looking at D-dimer is incredibly important, and I believe this is across our emergency medicine, hospital medicine, and critical care colleagues, something that I would really want to emphasize and to monitor. The International Society of Thrombosis and Hemostasis particularly notes that markedly elevated D-dimers, 3 to 4 times the level of the upper limit of normal, may be an independent reason to admit patients because it could indicate that they are much higher risk for clotting than for our typical COVID patients. And the next slide is really going to provide a framework for evaluating that. So here are those guidance that comes from the International Society of Thrombosis and Hemostasis. And I'll start at the top. I'm not going to go through every aspect of this diagram, but I want to highlight some particular areas. The white box really indicates the type of test that you're evaluating and the order of importance. So D-dimer, by far the most important test, fibrinogen, the least important in terms of evaluating for COVID-19 coagulopathy. What's in blue indicates the considerations of what to do for those patients in that particular instance. Now, what I've read in the report doesn't note whether the coagulopathy is associated with more severe COVID respiratory disease. It specifically comments on the incidence of clotting associated with these elevated levels. And so, as you can see, it does say admit some of these patients if there are no other additional concerns, and you want to be monitoring those tests daily. Why? Because ultimately you may be considering what, and it does document it as experimental therapies to prevent additional thrombosis. I'd encourage you, and in subsequent slides, it will underscore where to go to get this management pathway as well as the specific medication considerations. But I want to make sure to highlight that, again, that markedly elevated D-dimer may be an independent reason to have patients admitted. What's in green is really what to do for our typical COVID patients that aren't bleeding and how to monitor them for coagulopathy. What's in red is really going to be addressed on the subsequent slide, and it's what to do for our bleeding patients that still may have COVID and be at risk for the coagulopathy. So we'll go into the next slide. Now, again, these are clinical considerations for the unique patient. These are unique patients that are COVID positive, have signs of coagulopathy, at least in terms of laboratory findings. First and foremost, patients who aren't bleeding don't need lab correction. That seems fairly obvious, but we know that sometimes people treat the lab as opposed to the patient, and the recommendation that comes from that International Society of Thrombosis and Hemostasis, and actually supported by the American Society of Hematology, specifically indicates patients not bleeding don't need to go in and correct the labs. For patients who are actively bleeding, obviously we can have GI bleeding patients that have COVID, unfortunately. And for those, if the platelet count is below 50, you want to consider transfusing platelets. If the patient has an INR of greater than 1.8, you want to consider giving fresh frozen plasma. And for diminished fibrinogen levels, you want to consider giving fibrinogen concentrate. Specifically for our critically ill patients, ICU patients that are bleeding with COVID and the coagulopathy, the consideration is to use 4-factor prothrombin complex concentrate. That's hard to say. It's not something that I've used, but the specific indication, the reason why they would recommend that this is used is very specifically because, as we've stated in prior webinars, volume status is a significant concern, and some of the other blood factors that we've highlighted in terms of treating bleeding in COVID would put patients in volume overload, where we've previously shared that we want to make sure that patients are a little closer to the dry side. Next slide, please. Now, I know I just discussed bleeding and I was really discussing specific cases, but the final considerations I want to make sure that are available for us are about thromboprophylaxis. And these have again been discussed, but really want to highlight both the first and last bullet points. The first one is low molecular weight heparin is recommended for all patients hospitalized with COVID-19. Again, most of these patients who have COVID-19 are going to meet criteria for appropriate chemoprophylaxis with low molecular weight heparin, but it's one of the things we want to make sure to highlight, that we are making sure that we're considering what's going on for those patients. Lab abnormalities do not apply in terms of a specific contraindication. Excuse me. And finally, and as you would expect, mechanical thromboprophylaxis should be used when chemoprophylaxis isn't available. There are some reports and at least a few recommendations that indicate that for critically ill patients that we believe are at higher risk, you would want to use both low molecular weight heparin as well as mechanical thromboprophylaxis. But most of the guidance indicates that you should follow what your local recommendations are. The last bullet point is the part that I want to communicate, particularly for our, again, critical care colleagues who may be discharging patients to long-term acute care facilities, our hospitalists discharging patients back into the community or to skilled nursing facilities, and certainly for consideration for our post-acute care colleagues. Post-discharge thromboprophylaxis isn't generally recommended, but there are specific subsets of patients that should be considered. As you can see, there are specific drug recommendations with ventrixaban or rivaroxaban. There's actually a protocol that includes enoxaparin as well. But in considering the subset of patients that should receive post-discharge thromboprophylaxis, this working group around coagulation, or specifically anticoagulation, noted that these are patients that were paralyzed in the ICU. These were patients that had prolonged immobility, a generally prolonged hospital stay that was not specifically defined, but I believe it's considered anything greater than 10 days, or for any other reason where a patient would be considered higher risk for clotting. What are the individual regimens and for how long? That's dependent on the drug you choose. So as you can see, ventrixaban and rivaroxaban had different timelines for how long patients can be treated, but you can see that it is typically longer than the typical 30 days that you see. It's not on this slide, but also for patients who actually have thrombotic events, the recommendation is long-term anticoagulation for three months. I'll finish there and flip over to the last slide, which are really the references and additional links. Each of these was used for going over this particular section, and I found them incredibly useful. Many of the recommendations have changed in the last 3 weeks. I would anticipate that, like everything else in COVID, these will continue to evolve. But with that, I will end this section and transition over to Sergio.
Thanks, Greg. Thanks, Mark, for the introduction. I think echoing Greg's comments and Nate's sentiment, we really believe that well-being of our clinicians is paramount in terms of getting our teams to take great care of our patients, and that it's something that must be deliberate and intentional and not just by default. So I think that we should all be not only thinking of how we can help our colleagues, but also how we can take care of ourselves so that we can take care of our patients. So I'm gonna dive into an update on antiviral therapy. We talked about this not too long ago, but there's some new information. I'll talk today about chloroquine, hydroxychloroquine, just a quick update on convalescent plasma and remdesivir. I do wanna, before I start, just share that many of you may have seen some news releases today that it seems that one of the arms in the recovery trial, which is a large UK-based adaptive trial, seems to show a difference, a significant difference actually, with improved mortality with a low dose of steroids in the sickest patients. So we definitely will wait for publication of that, and we'll dive into that in the next webinar. But today we'll talk about these three agents and what's new in that respect. Next slide. So the hydroxychloroquine and chloroquine saga has been, I think, very controversial, very politically loaded, but I think it also has illustrated another aspect of science that we have never experienced to this degree, which is really, I mean, scientific misconduct and questions regarding publications. So the first small study that a lot of people took as their flag to propose hydroxychloroquine was done out of France by Professor Rolt. And that study was very small, had a lot of methodological questions, and there was actually a publication of concern emitted by the society that published that journal, stating that it didn't meet their expected standard. But that was not, this article was not retracted. A subsequent small study from France that was published and again was touted as positive was withdrawn and retracted due to inconsistencies. But more recently, you may have heard a lot of noise regarding two studies, one with hydroxychloroquine and the other one regarding ACE inhibitors, that were published in the Lancet and the New England Journal by a group that included academicians, one of them from Harvard, but also was based on a very large commercial database from a small company that also delves in AI. And this study initially was questioned by a lot of scientists. Obviously, it had a very large N. It was an observational database study with 96,000 patients that suggested that hydroxychloroquine not only didn't work, but could be harmful. And when people started looking at the methodology and the study in more detail, a lot of questions arose that really led to the inability of the investigators to show the data, and a retraction of both papers in the New England and the Lancet, which obviously, I mean, in the world of high-profile journals, is a big deal. So clearly, a lot of controversy back and forth. I think people who believed either based on the science that was very limited, or other or wishful thinking that hydroxychloroquine or chloroquine would work, point to the Lancet study, and those who obviously don't believe that it works point to the Rialt study as being retracted. But the truth is that we are seeing emerging data, and the FDA yesterday had a new decision regarding hydroxychloroquine. So next slide, and I'll go through these very quickly. But studies that were not retracted included two publications in the New England Journal of Medicine that were observational studies from New York. The first one by Galeras and collaborators included almost 1,400 patients, and this was an observational study of patients who received hydroxychloroquine and those who did not receive hydroxychloroquine. And basically what they were looking for was a combined endpoint of either intubation or death. And what they found is that there was no significant difference, but it seemed that it was more likely that to happen in patients who were treated. So this was a negative study related to hydroxychloroquine. Next slide, please. This is a similar study also from New York by Eli Resenberg and collaborators. And this again had approximately 1,500 patients, observational, and they looked at patients who got no drugs, patients who got hydroxychloroquine and azithromycin, hydroxychloroquine by itself, or azithromycin alone, which I presume was given mostly as an antibiotic. And what you can see is that the highest risk of death in hospital was with the hydroxychloroquine and azithromycin, and there was really no significant improvement when you gave hydroxychloroquine by itself. So this again was a negative study. In this study, they also showed that the combination of hydroxychloroquine and azithromycin increased the risk of cardiac arrest. So this was just another observational study that did not show any signal of benefit. But again, it's hard to make final conclusions based on observational studies. But then when you put these together, it's over 3,000 patients and really no signal that hydroxychloroquine by itself or in combination with azithromycin helps, and potential signal for harm. Another piece of information that is not available yet in peer review publication is the arm of hydroxychloroquine from the recovery trial, which is the UK-based trial that I mentioned earlier with steroids, also showed no benefit of hydroxychloroquine. And finally, the last study that was published that's recent and came after our last webinar is the one that looked at the use of hydroxychloroquine, next slide please, for prevention post-exposure. And this is obviously the modality that President Trump utilized, hydroxychloroquine. And here what they did is they took a group of physicians, mostly first responders and healthcare providers that were exposed. They evaluate them. They randomized 921. Some of them were excluded for different reasons. 821 actually that were asymptomatic and were included in the analysis. Of these, 414 were assigned to receive hydroxychloroquine and 407 were assigned to receive placebo. Now, pulling this study, this was based out of the University of Minnesota in the midst of a pandemic, obviously is very difficult. This is not a perfect study, but it was the first randomized study looking at people who are at high risk, either from household or healthcare exposures or occupational exposures, and randomizing them to hydroxychloroquine versus placebo. And what you can see is that there was absolutely no difference in the rate of new COVID-19 on day 5, day 10, and day 14. So really a negative study suggesting that there's no benefit in using hydroxychloroquine as a post-exposure prophylaxis. So based on all these studies and probably the recovery study as well, and other trials that were halted due to safety concerns, next slide, the FDA yesterday released basically revoked the emergency use authorization for hydroxychloroquine and COVID-19 patients. So I think that at this point, with the available evidence, using hydroxychloroquine or chloroquine in patients who are hospitalized is not based on science. It's not what's recommended. I think it could be harmful. And there's also no evidence that using it as a post-exposure prophylaxis is recommended. So I think that even though a lot of people were very adamant and enthusiastic about this drug, I think that based on the information we have right now, and I think there's more things that are coming out the pipeline, the hydroxychloroquine, chloroquine lane should be closed in our patients, and we shouldn't really be prescribing this or talking about this anymore as a drug that should be utilized in COVID-19. So let's move on. Let's talk about Remdesivir. This is the first study that just looked at the use of Remdesivir as a compassionate basis, suggesting that the majority of patients who got it had some sort of improvement. Obviously, this is just an observational study. And it's not a randomized study, but I think it gave the basis for the use of Remdesivir in clinical trials, at least. Next slide. The first clinical trial that was published came out of China. This was a 2-to-1 randomized controlled trial where they used a regimen of 10 days of Remdesivir, 200 milligrams IV on day 1, and then 100 milligrams per day on days 2 to 10. They randomized 158 patients to Remdesivir and 79 to placebo. The endpoint was time to clinical improvement by day 28. Unfortunately, this study was stopped early due to the pandemic kind of coming down and the numbers of patients decreasing significantly in China, and they had a hard time randomizing new patients. So it didn't complete the initial power estimate that they had. They kind of got halfway there, but they published the results, and it was a negative study that didn't show that the endpoint was any significant difference between Remdesivir and control. And when they looked at the viral loads in some of these patients, also there was no significant difference. So this was obviously a negative study. It was the first randomized study. A lot of people do mention that it didn't complete its fulfillment of what the original estimate for the number of patients was, but I think it's important to share because it was the first peer-reviewed published randomized study. Next slide, please. This is the preliminary report from the adaptive trial that's run by the NIH, and that included over 1,000 patients in with COVID, and basically what they did is they randomized patients to Remdesivir versus placebo. The results of these trials were shared preprint by Dr. Fauci in some interviews, and based on the findings in this study, where they found that the endpoint, which was a decrease in the composite, score of symptoms by 2, was significantly different, and that on average, the median time for recovery in placebo was 15 days, and for recovery in Remdesivir was 11 days. So based on these preliminary results, they released this study. They're continuing to analyze this, And the endpoint here was not mortality, it was improvement in symptoms. And what they said is that remdesivir can decrease the time to recovery in a statistically significant form in those patients who have severe disease, which is those who require oxygen or are intubated or on ECMO in the ICU. So based on this, as you'll see, the FDA released an emergency use authorization for remdesivir. There's an additional study, next slide please, that was published after this, where they compared regimens of 5 versus 10 days. And what's important here to note is that in those patients who are not intubated or are not on ECMO, there seemed to be no difference in terms of using 5 or 10 days. And these two studies are the basis for the current recommendations on remdesivir. Next slide, please. As of now, the emergency use authorization by the FDA for remdesivir includes patients who have COVID-19 with severe disease as defined by a saturation of oxygen of 94 or below on room air, or the need for supplemental oxygen, mechanical ventilation, or ECMO. Caution is recommended for those patients who have liver and renal failure, and the current dosing regimens that are recommended are for those who are intubated or on ECMO, a 10-day regimen, which includes 200 milligrams IV on day 1 and 100 milligrams on the subsequent days. And for those patients who are not intubated, who are supplemental oxygen but hospitalized, a 5-day regimen with 200 milligrams on day 1 and 100 milligrams on day 2 to day 5. I think additional instructions for healthcare providers have been provided by the FDA and the CDC, and it's important for us to tell our patients that we're using this under an emergency use authorization, that this is not an FDA-approved drug yet for COVID-19. It's important for us to explain the options and that patients and families have an option to refuse or accept the use of remdesivir. So this is not something that we should do without consent. We should inform them of the potential risk. And it's important that we give these patients and families written information on remdesivir, which is available through FDA links that are provided in the slides here. So I think it's important for us to understand this. Finally, these are the links, and they'll be emailed to everybody. And finally, I want to talk about convalescent plasma, which is obviously something that was utilized back in 1918 for the influenza pandemic. And the idea is very simple, that those patients who have recovered from COVID-19 have antibodies that we can use plasma rich in those antibodies, either as prophylaxis or as therapy for patients. This is something that a lot of our patients are receiving in the hospital. There are several registries that are giving this, but as of now, I think it's still experimental. There is one trial that has been published, next slide, which comes out of China. And very similar to the study I shared with remdesivir, this study was stopped because of lack of enrollment, because the pandemic kind of waned off where they were doing it. They were able to take 100 patients, 52 randomized to convalescent plasma, and 51 received standard of care. This was not obviously a double-blind study. You can see here some of the other characteristics. What's important to note is that the majority of these patients got the convalescent plasma almost 14 days after they started symptoms, which might be a little bit late. But I think it's important to recognize that. And also, I think a positive of this study, that this is the first study that actually puts standards on the plasma, measuring the levels of antibodies and having a threshold by which the plasma would be considered to be useful. So I think that that's also important. It's not just taking plasma and giving it to people who are sick, but making sure that the concentration of antibodies is appropriate, that there's a standardized ways to approach this. But this study, again, did not reach its intended power of recruitment. Next slide. The endpoint was to see an improvement of 2 points in the symptom scale that goes from 1 to 6. And what you can see is when you look at all patients, there was no significant difference. When you look at those patients that had severe disease, it seemed to be a little bit of a benefit with convalescent plasma that we could not see in those patients who were life-threatening, which again, I think we need more studies, but might suggest that if plasma has a role, it might not be late in the ICU when they're life-threatening disease, but it might be a lot earlier in the disease, and that's still something that people are trying to figure out. But still, people are receiving plasma through different registries and randomized trials, and I think both remdesivir and plasma are currently being utilized in a lot of the patients that Sound Physicians cares for. So this is the final recommendation from the NIH as of now, which is really that that there's not enough data, that we should do it within the confines of either a registry or a trial, and that hopefully we'll learn more about this in the upcoming months. Next slide. And I think with that, I'll pass it back to Nate.
Thanks, Sergio. So an awesome recap of the state of the art on treatment. I wanted to talk a little bit about what's happening in emergency medicine, what's happening in emergency departments across the country, and add a little bit of data and rigor to some of the discussion we've had before. So this is from the National Syndromic Surveillance Program in the US, which tracks ED utilization across a variety of regions. And you could see the huge kind of hockey stick shaped curve here, which shows, we were trending along at a typical, just under 2.5 million ED visits per week nationally, and then fell radically to less than half that with a nadir in about the 16th week of the year. And we've now started to experience kind of a slow recovery. And really our experience at Sound exactly matches that. This is weekly ED volume in Sound emergency departments. And what we've seen is a huge drop off, and then, some recovery in volume. And as that volume's recovered, we've seen some change in the types of patients presenting. And I want to highlight some of those patterns just so everybody can have a deeper understanding of what's occurring. And what are some reasons why volume is down so tremendously? I think really the first bullet point is the chief reason, which is that people are avoiding care due to fear of either being exposed or contracting COVID-19. They see hospitals as niduses of infection to be avoided. I think less significant, but also important, is the final bullet point showing, or basically fear of unnecessarily consuming resources. And the news media tends to focus on extreme outlier cases, and I think this drives behavior in a way that's really demonstrably harming Americans. It is true that as scheduled appointments and routine medical care and elective procedures have fallen off, those are definitely drivers of ED visits, as are commuting by motor vehicle and working in dangerous jobs, both sources of accidents that drive ED volume, and those are certainly down. But and if you look at the experience regionally, this, given our time pressure, I'm not going to go through in detail, but basically every region of the country experienced pretty substantial decline. This is from the same database that from the HHS that looks at all ED visits. And really one of the patterns that's interesting in all this data, this is number of ED visits using a snapshot before and after the pandemic. The dark blue bars are, sorry, not before and after, but before and during the pandemic. The dark blue bars are during the pandemic. And if you look at that 0 to 10-year-old age group and the 11 to 14-year-old age group, in kids, young children, those under 10, are responsible for a substantial fraction of ED visits, and the volume there fell by 75–80% in some cases. And then you see a decline. The magnitude of the decline drops slowly as you go to increasing age buckets. So what types of patient presentations weren't we seeing? And this is a case series from Beth Israel and some associated hospitals in Boston. And I would call your attention to the stroke line. And if you think about, Greg highlighted some of the thrombotic risk with stroke. Certainly in emergency departments, we were seeing atypical stroke presentations in younger patients anecdotally. But if you look at the data more broadly and look at, well, how many doses of TPA were given, how many people presented within, time windows. If you look at the, kind of the difference in different estimate here, the number of patients presenting with stroke, if you compare the same time period in 2019 to the weeks during the pandemic, it's a tremendous fall off. And I don't think this is driven by a decrease in stroke incidence. If you look at myocardial infarction, this is registry data for ST elevation MI activation. And, you can see the red bars on the rightward side of the bar graph showing really just a tremendous fall off in March. If you compare, you had 208 STEMI activations in the hospitals that participate in this particular registry in 2019, and really a trend of slight volume growth over the subsequent time period, and then that fell off dramatically in March. And again, I don't think that anyone believes this is because the incidence of STEMI was declining. There's a substantial fraction of people who are so afraid to come to the hospital that they're weathering their heart attacks at home. And the EMS data from New York City during the pandemic is perhaps the most illustrative of this. And if you look at the number of calls per day and the intensity of calls, the peak of daily calls that was seen during the pandemic in New York City far eclipsed the number of calls on 9/11 on a regular basis. And the light blue line is the trend line for 2019. And you can see in 2020, there were just shy of 4 times as many cardiac arrest calls during the same, these are couple day periods. Cardiac arrest calls that resulted in, a death in the field also, went up tremendously. I mean, a multiple of the pre-pandemic levels. And this is emblematic of, this is a geography where obviously the healthcare system was tremendously stressed, but also underlines this point that, I think we as physicians have a duty to get out the message that people are listening too well to the staying at home order, and they're listening so well that they're really being harmed. And in emergency medicine, we're not seeing a return to normal operation at a pace that is making sense for the health of the communities that we serve. And I think there's a couple of things incumbent upon us to help fight against this dynamic. And one of them is to really become evangelists for, information, and to try and work against the dynamic that's at play in the popular media, where there are, extreme outlier cases that are publicized, and to focus on things like, well, what are we doing different at our hospitals to keep patients safe? And talking about things like cohorting patients with COVID-19, enhanced cleaning, screening of both patients and colleagues on entry of the hospital, making sure that the public understands which services are available. And getting this message out is something that, I just can't emphasize how important this is. And the registry data on MIs is just really compelling on this front. So with that, we have 1 minute remaining for questions. Mark, have we had any questions from the audience today?
Thank you, Nate. We have not had any questions. That was a really fascinating presentation, and it just underscores the impact that this pandemic has had on everyone, whether affected directly or indirectly. I mean, it's just so profound. I'm just curious, Nate, were you surprised to see when you saw some of those graphs and that data? Is that surprising to you, or is that what you would have expected when you started to see that people were just staying away from the emergency room?
I knew from anecdote and from working clinically myself that the pattern of patients that were presenting had changed radically. And initially, when the lockdowns were in place, we and work and normal life was restricted dramatically, we felt like, boy, there'll be a little adjustment period, and then we'll start to see those sick patients again. But as studies started to come out and as this registry data became available, the scope of the problem became apparent. And then that EMS and 911 data from New York City was just a wake-up call, and has really led me and a lot of folks on the EM team to be spending a lot of our time trying to get this message out.
We did just get one question, so we'll take this one question, especially since it's related to the topic at hand. The question is, how much of the pediatric population didn't come in because their parents rethought bringing their kids in the emergency room because it wasn't that serious? Do you have a sense of, the changes there?
Sure. So if you think about what are the drivers of pediatric emergency department visits, infection and accidents are the top two things. And one of the consequences of widespread sheltering in place is that there's a lot less social interaction and school was canceled. So you have a little bit, a substantial decrease in kind of the normal infections occurring. And then on top of that, if you look at the impact of COVID-19 on different age groups, there really, as you go on each decade in age, I think there's still only a handful of deaths in folks under the age of 8 reported in the US. So that the pandemic itself really hasn't impacted that age group. And then if you look at a lot of the behaviors that would result in accidents that would drive emergency department visits, things like playing on your soccer team or going to the park, these are things that people are just not doing. So I think the combination of all those things, and really, I don't think anyone prospectively predicted this trend. When doctors' offices started to close and it became difficult or perhaps impossible to see your primary pediatrician in their office, we really were bracing for, some increase in volume. And for the reasons I mentioned, it didn't come.
Yeah. Well, I think that's great advice, that we can start being a part of the team that is suggesting to folks that it's safe to go to the hospital and to seek care when they really need it. We are a couple minutes after the top of the hour. I want to thank Sergio and Greg, and of course, thank you, Nate, and thanks for giving me the opportunity to talk a little bit about well-being. And thanks to all of you out in the field who are tuning in and supporting these efforts and doing such a great job taking care of the patients in your communities. We're grateful for what you're doing every day and look for further information about future COVID clinical webinars. Thanks, everybody. Have a great day.